So at this breakout session, Dr. Anthea Peters, a hematologist from Alberta, will review the disease-specific biology of diffuse large B-cell lymphoma and other aggressive non-Hodgkin lymphomas, and will examine the current Canadian treatment options available. Dr. Peters is an expert in DLBCLs and NHLs and will further highlight some treatments coming to Canada and the research and results behind new therapies and clinical trials. Today, we welcome Dr. Peters, a hematologist currently appointed as an assistant professor in the Division of Hematology, Department of Medicine, and cross-appointed to the Department of Oncology at the University of Alberta. Dr. Peters' clinical and research interests surround lymphoma in adults. Thank you, Dr. Peters, for taking the time today to present on this topic to the lymphoma community, and we look forward to your presentation.
Great. Thank you so much, Caitlin. Yeah, so as Caitlin mentioned, I am a practicing hematologist in Edmonton, Alberta, and I'm actually at the Cross Cancer Institute. So I treat all things lymphoid, so lymphoma, CLL, some other lymphoid leukemias as well, but only adults. So I'm going to cover, it's going to be quite broad in the beginning, but I will cover the following topics, basically starting at what is aggressive lymphoma. I'm going to focus only on diffuse large B-cell lymphoma primarily, as well as mantle cell lymphoma. There's just not enough time to get into all of the different subtypes. Then we're going to talk about what determines the prognosis of a patient with aggressive lymphomas. Focusing on patient factors as well as disease factors. And then we'll end off talking about how aggressive lymphoma is treated. So I've got a few slides in the presentation with pictures of Edmonton's beautiful river valley. And the story behind it is that I had the pleasure of participating in Laps Around Lymphoma, which was a fundraising effort through Lymphoma Canada this year. I think it was the first year it had run. And so kind of got a motivation to get out and walk around the university and River Valley area and snapped a few shots that I just thought I would share. So first of all, we're going to talk about what is aggressive lymphoma, starting very basic at what is lymphoma. And basically, lymphoma is a heterogeneous group of diseases characterized by infiltration of lymph nodes, spleen, bone marrow, and other tissues by abnormal proliferation of lymphoid cells. And I've just shown here in a diagram sort of the most common areas of the body affected, and we'll talk a bit more about it. So this includes lymph nodes, which are scattered around the body, spleen, bone marrow, and blood, and other areas outside the lymph nodes as well. So lymphocytes, those are actually the cell that lymphoma arises from. And so this is a cell that forms a major part of the immune system. These cells develop in the bone marrow and thymus early in life, and they actually travel around to different areas of the lymphatic system. Their job is to recognize invaders, such as bacteria, viruses, and others, and form or sort of initiate an immune response to those invaders. And so this involves duplication of the cells. And anytime you have duplication or division of cells, there's always potential for error. And that error sometimes leads to cancer cells forming. Keep in mind that sometimes you may have lymph nodes that are enlarged due to other reasons, and that can be, I've divided them into localized and generalized. And what I mean by that is sometimes lymph nodes are enlarged in one area of the body, such as the neck on one side, or the groin on one side. and other issues cause a generalized enlargement of lymph nodes. And you can see from the list, not getting into too much detail, but there are several other things that cause enlarged lymph nodes other than cancer. The presentation of lymphoma, you'll recognize this photo from my first slide. This is typically how lymphomas present. So patients would develop potentially enlarged lymph nodes. Some of those lymph nodes are detectable by physical exams, such as in the neck, armpits, and groin. Sometimes not, though. Sometimes they're in areas like the chest or the abdomen, where they could be even quite large, but a physical exam would not necessarily detect it. The spleen becomes enlarged when involved by lymphoma. The bone marrow becomes infiltrated, and this typically results in low blood counts. So just think of the bone marrow being occupied by abnormal cells, and then its ability to make normal blood cells is going to be impaired as a result. Sometimes blood is involved as well, not always, and this is actually not very frequent with aggressive lymphomas, but it is possible. And then some areas outside the lymph nodes can be involved. So there's listed here testes, skin, kidneys, but many, many others. In fact, essentially any area of the body could be involved. So how do patients discover that they have lymphoma? I kind of alluded to this, but certain symptoms could make your doctor suspicious, such as enlarged lymph nodes or unexplained weight loss, for example. But there's many different ways. Ultimately, the doctor would order imaging that would show these abnormalities, such as enlarged lymph nodes. So we have typically ultrasound or CT scan. And that's not the end of it. You end up having to have a biopsy to prove that whatever was found on imaging represents lymphoma. And not only that, we have to determine the type, because the type of lymphoma is very, very essential to how we treat it. And I didn't want to share the entire list of lymphomas because it is extensive and quite intimidating when you look at it. So I typically break down the types of lymphoma into big categories, and the big categories are non-Hodgkin versus Hodgkin lymphoma, and today we'll be focusing on non-Hodgkin. There's also a big split within non-Hodgkin into B or T cell, and that kind of refers to the types of lymphocytes that are found in the immune system. So whichever type of lymphocyte led to the lymphoma, that's what we're going to find. Today we'll focus on the B cell lymphomas. And then within the B cell lymphomas, you have even then a big list. So we typically think of them in terms of how they behave clinically. And I'll sort of get to what I mean by that. But basically, today we're going to focus on aggressive lymphomas rather than very aggressive or indolent. And we'll, again, focus on diffuse large B-cell lymphoma and mantle cell lymphoma. And just touching a little bit more on aggressive lymphoma, what does that refer to? To go into that in a bit more detail, it refers to how quickly the cancer grows, how patients typically feel when they're diagnosed with aggressive lymphoma, and how the cancer responds to treatment. So I have a few more slides just discussing that issue and comparing and contrasting between aggressive and indolent lymphoma. So within aggressive lymphomas, the cells of the lymphoma tend to divide quickly, and thus the tumors grow quickly. whereas in indolent lymphomas, these cells divide quite slowly and hence the tumors grow slowly. The second point there is that patients more often have systemic symptoms. So these are things like fevers, persistent fevers, weight loss, night sweats. Those are referred to as B symptoms. And those are more common in aggressive lymphomas than in indolent lymphomas. And typically patients with aggressive lymphomas require treatment right away, whereas with indolent lymphomas, patients may not require treatment right away, and they can often go on to a watch and wait type of approach. And once treatment is instituted, the aggressive lymphomas do tend to respond quite quickly to chemotherapy or radiation or whatever the treatment may be, whereas indolent lymphomas tend to shrink more slowly. Finally, aggressive lymphomas, as a general rule, can be cured with treatment, whereas the indolent lymphomas, generally speaking, cannot be cured, but can go into remission with treatment. The exception to this rule being mantle cell lymphoma, as although it tends to behave in a more aggressive fashion, and we tend to put it with the aggressive lymphomas, it is the exception to the rule that it's at this point we are not able to generate a cure for patients with our current treatment. And so how is my stage determined? This is an important consideration, although in lymphoma, not sort of the most important factor in deciding treatment. Patients tend to undergo body imaging as the primary source of staging. And currently with aggressive lymphomas, we tend to think that PET scan is ideal. If we have access to PET scan, we would prefer to have a PET scan. The reason being that you know, CT scans do identify enlarged lymph nodes and masses that we can measure. However, sometimes there are areas of involvement that are not measurable, such as involvement in the bowel wall. And PET scan can really be helpful in those scenarios. So, you know, in fact, there's a chance that your stage would be upgraded with a PET scan because it identified an area of involvement that the CT didn't find. It is certainly gold standard for diffuse large B-cell lymphoma, but not necessarily for mantle cell lymphoma. Bone marrow biopsy is not routinely done anymore for staging. It used to be done, but now we rely on PET scan to tell us whether there is a suspicion of bone marrow involvement. If there's any sort of doubt or whether there's some problem with the blood work and the blood counts in particular, your doctor may decide to do a bone marrow biopsy to investigate that further. All right. So I'm going to now turn to the subtypes of lymphoma and talk a bit more detail about the features and biology of these diseases. So we'll start off with diffuse large B-cell lymphoma. And this is the most common non-Hodgkin lymphoma subtype, making up about 40%. And it is a very diverse group of lymphomas in terms of its clinical behavior. What I mean by that is that there's a large variety of areas of the body that can be affected by this type of lymphoma. For example, you know, it can present in the classical way with enlarged lymph nodes or spleen, but we do see some patients who have none of that and actually only have involvement in the brain. Or there's certainly any other area of the body that can be affected. So it's very variable. It's sort of the classical type of aggressive non-Hodgkin lymphoma, and its course tends to be clinically aggressive. Over half of patients, fortunately, are cured with R-CHOP chemoimmunotherapy, and that is currently the gold standard treatment, and has been for over a decade. Though unfortunately there are still a large number of patients that are not cured with chemoimmunotherapy, and their prognosis tends to be less good. And I'll just introduce mantle cell lymphoma as well as a much rarer subtype of non-Hodgkin lymphoma. This one tends to occur in the 5th or 6th decade, and for some reason is predominantly found in males. It also tends to have an aggressive clinical behavior. There is certainly an increasingly recognized patient population with mantle cell lymphomas that are quite indolent, and some even emulate CLL, where they just have a blood involvement and bone marrow involvement, but no lymph node involvement. So it also is quite variable in presentation and behavior. And as I mentioned prior, although it's an aggressive lymphoma, it's not doesn't tend to be curable with chemoimmunotherapy. And just to point out as well that there is a biological variant called blastoid mantle cell that is particularly aggressive. The very relevant question of whether patients will be cured with treatment is something that we can only rely on statistics to try to answer. And it is rather unsatisfying because it doesn't consider each individual patient, but it is the only tool that we have. And so we have over the years come up with these prognostic scores for these different types of lymphoma that use statistics in a big population of patients that have gone through treatment previously. So the IPI score is the classical one that we use for DL.BCL or diffuse large B-cell lymphoma. The MYCrearrangement score is the one that we use for mantle cell lymphoma, and I'm going to go through that in more detail. And also we'll dive into the biological markers that add valuable information in both diseases. And just as examples, the MYC gene in diffuse large B-cell lymphoma and the % of dividing cells or proliferation index in mantle cell. So first of all, the IPI score it stands for International Prognostic Index. And there's 2 patient factors. Each of these factors, by the way, out of 5 give you 1 point. So the 2 patient factors are the first one, of course, that you can't change or control, but age over 60. The second being ECOG Performance Status. And I'm not sure how many patients or people are familiar with that scale, but essentially we give 1 point if we judge a patient's performance status to be worse than 1. So I put on the next slide the details of that scale. And so ECOG 1 would be a patient that is still ambulatory but can't do physically strenuous activity. Is able to do sort of work as in light housework or office work. Whereas anything worse than that, such as 2, so this would be you're ambulatory and capable of caring for yourself, but not able to do any sort of work activities, but you're still up and around more than half the day. So that's a glimpse into how that is determined. Pardon me, I'm just flipping forward. So next is the 3 disease factors, first being advanced stage 3 or 4. Secondly, lymphoma involving more than one site, not including lymph nodes. So that's called extranodal sites. And then finally, the LDH being high. And LDH is actually a very non-specific blood test that happens to reflect how much cell turnover is going on in the blood. And what does that score mean exactly? So we give a patient a score out of 5. And this score represents, sort of corresponds to a percentage chance that you would achieve cure with treatment. So this sort of assumes that you're going to go through all full dose chemotherapy with the gold standard being R-CHOP. And statistically, if you have a low risk IPI score, your chance is about 90% of achieving cure. It drops down to 70% with IPI score 2, and then further down to 55% if your score is 3 to 5. All right, so 55% is sort of the worst case scenario. Okay, so I want to just turn to talking a bit more about the biology of DLBCL, and I think we could have spent the entire session talking about this because it is very complex and evolving as we speak. So it turns out that this disease is really, to a pathologist's eyes, rather monotonous. So in other words, the cells by definition appear similar in size and appearance, and they cluster in a big group. And so that's sort of how the pathologist recognizes that they're abnormal and that they represent this particular disease. But they need to look further into what these cells are, and they typically use something called immunohistochemistry, which I'm going to talk about in more detail in a moment. And then we'll turn to talking a little bit about other significant features that have been identified. These have come from very advanced testing with advanced molecular techniques in research labs, and some of those techniques have been adapted to things that we can do in a clinic setting, whereas some are just out of reach in terms of costs and accessibility for clinical practice. Okay, so on the left, I sort of drew a picture of a bunch of lymphocytes on a slide that appear very monotonous and similar in size, and that's again how pathologists recognize these diffuse large B-cell lymphomas. But using immunohistochemistry and something called flow cytometry, they can actually look at invisible markers on the cell's surface and expressed within the cell. And that's how they come up with the final diagnosis of diffuse large B-cell lymphoma. A couple of the characteristic markers include CD20 positivity, CD19 positivity, and that's just represented by these dark circles around the cells and red circles around the cells. And so they use multiple slides and multiple markers to get down to the pattern of what they're seeing, and then they can eliminate other types of disease, other types of lymphoma. They can also use these markers with immunohistochemistry to give us a better idea of the subtype of diffuse large B-cell lymphoma. So some researchers found out that using very advanced molecular techniques that there is something called germinal center B-cell subtype and non-germinal center B-cell subtype. And just by looking at them, you wouldn't know the difference, but looking at their gene expression profile, you can separate the two. Of course, we don't have that available in the clinic, so we try to simulate that using immunohistochemistry. So that's one of the things that your doctor can tell you based on what the pathologist reports. And for some reason, the ones that are germinal center B-cell subtype tend to have a superior duration of remission. And other biological factors play a big role, but these features of DL.BCL continue to evolve over time, and we're learning more and more about them. And I just have on the left there a picture of a cell which contains chromosomes, which when you unravel are consisting of DNA, and encoded in the DNA is genes. Those genes are then translated into proteins, and the proteins are what actually enable the cell to function. So using molecular techniques, we look at very specific genes on chromosomes to try to identify some of these features of diffuse large B-cell lymphoma. So using a technique called FISH, we look at translocations on chromosomes. And so far, we have identified 3 main translocations that are of interest. The first and probably most important is one called MYC. And this is a gene that, when overactive, makes the cell grow out of control. And so typically, the pathologist would send cases off to get tested for this MYC gene. And if positive, then they would look further into whether they have an additional chromosome translocation, BCL2 and BCL6. And you know, if both of those are positive, then we give the diagnosis of triple hit, referring to how many translocations there are. If there's one of those, BCL2 or BCL6 present, we refer to it as double hit. And if neither of those are present, then we simply have the MYC positivity. And it seems convincing in studies that if you simply use R-CHOP chemotherapy, which is the standard for a lymphoma that's double or triple hit, you do not get the results that you want. So patients do not do as well with those. They have shorter remissions, and they tend to relapse quickly after R-CHOP chemotherapy. So the practice has changed in the last few years to intensify chemotherapy when we're dealing with these more aggressive subtypes. The picture is certainly not as clear with regards to positivity of just MYC, but at this point, it does not appear that they require more aggressive chemotherapy, but we certainly worry more about these patients and watch them more closely. Now, turning to mantle cell lymphoma, we'll look at the prognostic score for mantle cell lymphoma, which is the MYPI score. And it actually shares the same 2 patient factors, age and ECOG performance status. And I apologize, this should read 3 disease factors, but these are a little bit different. So rather than worrying about the stage of mantle cell lymphoma in this particular score, we look at 2 lab tests, one of them being the white blood cell count, and the other being similar to the last score, a high LDH. Again, these are both blood tests. And then the last one is one that we rely on the pathologist to give us, and that is the percent of mantle cell lymphoma cells that are actively dividing in the tumor. And it's not a simple 5-point scale, unfortunately. So we actually sort of log into a calculator that's available online and come up with a score that gives us either low, intermediate, or high risk. The other interesting features, there's a lot of interesting features about mantle cell lymphoma, but just really briefly, I mentioned already that a blastoid variant mantle cell lymphoma is more aggressive, and that is another one we rely on the pathologist to tell us, but in fact, typically we would not give standard treatment. We would want to intensify treatment in that scenario as well. And then there's also been recognized a mutation, a gene mutation that would give patients less success with chemotherapy. Unfortunately, I know in Edmonton, we don't have access to that particular test within our lab, so we do have to send that out. And it's not clear at this point who really needs to have that test done. So I think this is my last picture of my River Valley adventure. We're going to turn to treatment now. So treatment of aggressive lymphomas is ever evolving, and the treatments that are available in Canada, we have certainly chemotherapy that's been around for decades. We have monoclonal antibody treatment, targeted medication, radiation, and stem cell transplant. And then, of course, we are advancing, luckily, to include CAR T cell therapy. So I'll touch a little bit about all of these modalities. But as an overall statement, the major advancement in the treatment of B-cell lymphomas, including aggressive and indolent lymphomas in the last 2 decades, has been the addition of antibody treatment. And that's, for the most part, anti-CD20 antibody called rituximab. And so this drug recognizes a surface marker on the cancer cells called CD20 and signals the immune system to eliminate the cell. This treatment makes chemotherapy work better. So it's always paired up with chemotherapy. I shouldn't say always, but the vast majority of cases. And then secondly, just the fact that the first treatment you receive for this type of lymphoma tends to be the most important and the most gives you the best chance at remission. So we try to make the first treatment the more aggressive and effective. I did mention the word remission, so I just thought I would clarify a bit about that. Remission means basically that after treatment, the symptoms and signs of the cancer have diminished. And we can talk about a complete or partial remission, where a complete remission is no detection of the cancer by standard methods, typically by imaging. And partial remission means, yes, the cancer has reduced in size, but we can still see or measure it. But it is under control. Whereas the word cure is a little bit different. It just refers to the fact that the cancer has been under control for a long duration, and just arbitrarily we tend to use 5 years as that cutoff. So in terms of current treatment for diffuse large B-cell lymphoma, you've seen this slide already. I would say that by far the most common treatment is R-CHOP chemotherapy. But in those rare scenarios when you're looking at triple or double hit lymphomas, we would not be satisfied with R-CHOP. We would want to intensify chemo, and usually that involves something called dose-adjusted EPOCH-R or McGrath protocol, like a Burkitt type treatment. And those are, pardon me, typically done as inpatients in the hospital. And looking ahead, what would happen then if you receive treatment for DL.BCL and it comes back after treatment or relapses? And the first question that we would ask in that case is whether you are eligible for a stem cell transplant. The answer to that, it depends on age, usually 70 or younger, and your overall health. If the answer is yes, you are eligible for stem cell transplant, then we would typically give, again, rituximab, but a different type of chemotherapy that we usually call salvage chemotherapy. And then we actually perform what's called a stem cell transplant. So stem cell transplant, I tried to kind of find a nice infographic about it. And this is actually from the MS Research Society, I guess, in Australia. But basically, step one there is to administer some medication to release the blood cells or stem cells into the bone, from the bone marrow into the bloodstream, then collect the stem cells from the bloodstream. We actually freeze them or cryopreserve them until the time when they are required. We then administer some chemotherapy. That's quite aggressive chemotherapy and typically done in hospital. And then we reinfuse those thawed stem cells back in, much like a blood transfusion. And following that, we need to monitor and support patients because it takes several, well, usually 2 weeks for them to regrow the stem cells. In the meantime, people are very immune suppressed and relying on transfusions for support. So that is often used in treatment of relapsed lymphomas. If the answer is no, you're not eligible for stem cell transplant, usually that would mean that the transplant is too risky or toxic. And unfortunately, that's the only curative option we have currently. So a clinical trial or chemotherapy that hasn't been given before is what we would try. Now, upcoming treatments, we do have on the horizon another antibody treatment called polatuzumab vedotin, which I understand is just going through the approval process and hopefully will be funded because I think this area of relapsed diffuse large B-cell lymphoma is very much in need of new drugs. And so this one is specifically approved for patients that are not eligible for transplant. It's paired with a chemotherapy drug called bendamustine and also with rituximab. And so that should be available, I guess when I say soon, I mean probably within 6 months or so. And then most excitingly, CAR T-cell therapy is now becoming available in select centers and hopefully at most centers in the near future. And I know Dr. Foley is going to talk about this in detail tomorrow, so do not miss that talk because I think it's probably the most important development in lymphoma in the last few years. The basic idea is that we harness the patient's own immune system to target and attack the cancer cells by engineering patient's own immune cells to recognize the tumor cells, signal through the intracellular signaling, and activate and proliferate these T cells, and then give them back to the patient to kill the tumor. And without spending too much time on it, you actually do take the patient's own immune cells and then in the lab engineer them to recognize markers on the tumor cells and then grow more of them and give them back to the patient to fight the cancer. We have some other clinical trials, and I'm sure there's also many trials running across the country because it is well recognized that we need more treatment in this area. So I just wanted to mention a few. We have another exciting development called BITES, which is bispecific T cell engagers. And these are, again, antibodies with two receptors. So they're gonna connect the cancer cell and the T cells from the patient to be directly beside each other and use the T cells to eliminate the cancer cell. And then another antibody-based treatment called tafasitamab, which targets CD79 and again is paired up with chemo. So these are sort of in development. And at the Cross Cancer, Dr. Michael Chu has a homegrown CAR T cell therapy that we should be opening a trial for in the next month or so, where he manufactures CAR T cells here in Edmonton rather than using a commercial product to hopefully reduce the cost. I'm running out of time, but I'm going to talk about mantle cell lymphoma for a couple minutes. This type of lymphoma is primarily sort of treated with the most aggressive treatment possible up front. So we do actually perform a stem cell transplant to patients that are eligible right at the outset. So we give rituximab and chemotherapy. There's no current standard of chemotherapy, except to say that cytarabine seems to be a drug that's essential. Then we do a stem cell transplant, as I described before. And then following that, patients actually undergo maintenance treatment. If the answer is no, that you're not eligible for stem cell transplant, then we would still treat with rituximab plus chemotherapy and maintenance rituximab, but just skip the transplant portion. If the mantle cell lymphoma comes back, it is more resistant to treatment and more difficult to treat, but we do have more options. I think it's getting more rare and rare that patients would undergo allogeneic stem cell transplant. Ibrutinib is a very good option. This is a non-chemotherapy oral medication that's commonly used for CLL, but works remarkably well for mantle cell lymphoma as well. There's a drug called bortezomib used for myeloma that we can use for mantle cell. It also works well. And otherwise, you know, trying other chemotherapies that hadn't been given previously. Again, there's a large need for more medications in this particular disease. I'll just highlight that acalabrutinib is a medication that's, again, oral. It's related to ibrutinib, thought to be a improved version of ibrutinib, and may soon be available for relapsed and treatment naive MCL. And then a CAR T cell therapy is very effective for mantle cell, but unfortunately right now is not approved in Canada. I hope that soon it will be. But in the US, I believe that it is approved. So that was quite a whirlwind, but I hope that I was able to shed some light in a few areas, and particularly, you know, up and coming treatments. So just to summarize, aggressive B-cell lymphomas are highly variable in clinic behavior and biologic features. And the standard treatment cures over half of patients with diffuse large B-cell lymphoma, but many do not have access to curative treatments after relapse. Mantle cell lymphoma is generally incurable and is challenging to treat. Fortunately, research is very active in these areas and new treatments are being developed, but you'll notice a major pattern is that the treatments coming up are more so taking advantage of the immune system to help eliminate the cancer rather than relying on what we call cytotoxic agents or chemotherapy agents. And in particular, CAR T cell therapy, I would say is by far the most exciting. So that's all I have, and I would be very happy to now take a few questions. Hopefully there's some time. I think we have about 6 minutes left.
Yes, so we do have some time, which is great. So thank you, Dr. Peters. That was a very informative presentation about subtype biology and current and future treatments for DLBCL and other aggressive non-Hodgkin's lymphoma, including mantle cell lymphoma. There are quite a few types of aggressive NHLs, and we really appreciate the detailed overview you provided. So we do have just a few questions, so I'll jump right into them. The first is whether or not it's important to have a hematologist who is a specialist in that patient's type of NHL, and just making sure that that specialist is aware, and whether or not there is a movement of patients between specialists depending on whether they have experience with it.
Yeah, well, I would say that it is a complicated disease. It is definitely, I would say, essential for pathology to be highly specialized because nailing the exact type of lymphoma is critical. There's many people that treat lymphoma that are trained in it's a little funny because in Canada, there's some people who are trained in hematology that treat lymphoma. Depending on the center you're at, they may be a hematologist or an oncologist, like a medical oncologist. And, to be honest, we both get trained in lymphoma. So I don't think it has to be a hematologist or an oncologist, but, it's going to be one or the other. And I think, with anything, as long as they have some experience with lymphoma, that's critical.
Okay, great. And another patient had asked if not responding favorably using rituximab at any point in treatment, what would be used instead in combination with new drugs?
Yeah, so I actually didn't mention, but there is another anti-CD20 antibody that's available called obinutuzumab, or GA101. And it is in probably many provinces approved for relapsed refractory patients, and particularly patients that are refractory to rituximab. So it's again combined with chemotherapy, and it is when you're refractory to rituximab, it can give you really excellent benefit.
Okay, great. Uh, Another question was kind of related to, I guess, more of a future possibility about when CAR T will be available to everyone in Canada, and whether there are trials looking at CAR Ts and additional lymphomas as well.
Yeah, I knew that question was coming, and I reached out to somebody in the industry to ask about mantle cell lymphoma, and was told that it's not yet approved in Canada. But I know for diffuse large B-cell lymphoma and acute lymphoblastic lymphoma, or leukemia, it is approved in Canada. Now, whether your center has it is another question. So, like currently, I think in Alberta, we just approved it within 30 days ago for funding. And, so this is changing day by day. So, and right now, though, we've never actually performed a CAR T therapy in Edmonton. But the last two patients I'm aware of, one of them went to Toronto, one of them went to Mayo Clinic, and the government funded it. But the idea is that soon we will start gaining our own experience. Now, this is variable center to center. So, and province to province. So it really depends where you live. And my hope is that within a year, we are all going to be competent at CAR T cell therapy. I would say any place that conducts auto stem cell transplant should be capable
Okay, great.
of doing CAR T.
Okay, great. And I think we have time just for one more question. Low LDH.
Oh, low LDH.
Yeah.
So we care if it's a high LDH. We don't so much care if it's a low LDH. I would say that that's a normal LDH. So that is a good thing, because that does not give you a point on the prognostic scale. It's sort of counted as a normal result. So why it's low, I don't know.
Okay, great.
Yeah, I don't know why it would be low, but I've seen that before, and I kind of scratch my head and go, oh, well, I guess I would say that's normal. So.
Okay, fantastic. Well, Thank you to all of those who did answer a question. If we were not able to answer your question live, we will try to reach out to you specifically, or you can also email us at info@lymphoma.ca. Just as a reminder, all presentations will be recorded and placed on our Lymphoma Canada website. We just wanted to take the time to thank you, Dr. Peters, for your time and efforts to prepare for this presentation and share your experience on this subject with the lymphoma community.